Welcome everybody to part 5 of Dr. Manny's YouTube Learn Chops dealing with mechanical ventilation, and this looks at the nursing management. The objectives are to review the nurse's role or the healthcare provider's role and responsibilities when caring for a patient who requires mechanical ventilation, and also to discuss nursing interventions or care interventions when caring for a patient who is on a mechanical ventilator. Always remember, if there's a problem, always look at the patient first and then the machines, regardless of whether they're a ventilator, an infusion pump, or any machine. Always look at the patient first. Remember, how does the patient feel? Patients on a mechanical ventilator are usually very anxious and apprehensive. Common fears would be that the ventilator may fail and they'd be unable to breathe or call for help. Or they may even buck or fight the ventilator because they don't want a machine taking control of their breathing, regardless of the fact whether they can breathe or not breathe. What's the nurse's role? Well, in a wide variety of settings now, nurses are increasingly expected to care for patients on mechanical ventilators, whether it's in emergency departments, long-term care centres, intensive cares, HDUs, high dependency units, paediatric ICU, neonatal ICUs. Let's assume that you're one of them. What do you need to know to plan for your shift or how to care for the patient? Which patient assessment parameters are crucial? What evidence-based practice guidelines should you follow? The important thing from my perspective is always being a patient advocate. And the best way to think of being a patient advocate is to think, how would you like to be cared for if you were the patient? If you were intubated? If you were on a mechanical ventilator? A patient advocate, that's a nurse who ensures patients' quality of care and protects their patients' rights. They intervene when there is a care concern and, following the proper channels, chain of command, work to resolve any patient care issues. Realistically, every nurse, every healthcare provider is a patient advocate. Safety concerns include, for a nurse who's competent, is knowing how to provide basic life support, and they should be accredited. They should know how to care for the ventilated patient if they are allocated a patient who is ventilated, and be familiar with relevant resuscitation equipment if required to do so. If required to suction a patient, they should be familiar with the procedure. Their environment they should be totally familiar with in the event of something happening or the patient requiring assistance. And this does include calling a code blue if required to do so. Hand hygiene is an essential component, and following the World Health Organization's recommendations, be familiar with the 5 moments of hand hygiene. Before touching a patient, before a clean or aseptic procedure, after exposure to body fluids, after touching a patient, and after touching their environment. What are some of the psychological concerns that a ventilated patient may have? Put yourself in their situation. They could be anxious. They could be distressed. They may not be able to communicate effectively. They may be fearful, or they may have pain. Cardiovascular concerns that you might have are that mechanical ventilation may decrease cardiac output, which results in hypotension, fluid overloading as a result of decreased venous return. There could be vagal reactions due to suctioning as a result of hypoxia, or there could be acute pulmonary edema or ventilation perfusion mismatching occurring, primarily as a result of ventilation. And they can develop cardiac dysrhythmias or arrhythmias as a consequence. There could be gastrointestinal concerns because of decreased blood flow as a result of being on a mechanical ventilator, which results in a paralytic ileus. A stressful situation which promotes gastric or duodenal ulcers. They could be malnourished because you're not feeding them. There could be an electrolyte imbalance, acid-base arrangements. Because of immobility, they may develop constipation. They could also develop gastric distension because of air going into the gastrointestinal tract, the stomach. Other concerns that you might consider are incorrect ventilatory settings, hypothermia or hypothermia from the humidifier, equipment failure, accidental disconnection, pain management issues, concerns about developing a deep vein thrombosis because of immobility problems. So what's the nursing management then? The nursing management, mechanical ventilation is a common therapeutic intervention in critical care units, and not without concerns or complications. Recent practices have introduced ventilator care bundles to reduce complications of mechanical ventilation, especially those related to ventilator-acquired events or ventilator-associated pneumonia. The ventilator care bundle essentially consists of 5 elements: head of bed position, stress ulcer prophylaxis, use of chlorhexidine as oral care disinfectant, daily sedation assessment and assessment for weaning, and deep vein thrombosis prophylaxis. There are more, but these are the 5 essential elements. The head of bed position is the first one. It's recommended try and keep the patient in a semi-recumbent position. However, hemodynamically unstable patients will be excluded. Patients with pelvic and spinal trauma will be excluded. The head of position is recommended to be a minimum of 30 degrees, and this reduces nasal and oropharyngeal secretions, esophageal reflux, and pulmonary aspiration, which lowers the incidence of ventilator-associated pneumonias in comparison to laying the patient supine or prone. And this promotes more effective ventilation and drainage. Stress ulcer prophylaxis is the second. So gastric intestinal bleeding could occur just by being in a stressful situation, by being on a mechanical ventilator. Drugs and enteral feeding could reduce this incidence, and commonly prescribed medications are sucralfate, histamine 2 receptor antagonists such as ranitidine or cimetidine, proton pump inhibitors such as omeprazole. And if there's no contraindication to nasogastric or enteral feeding, it should be commenced after 24 hours being on a mechanical ventilator. The third one is oral care, which should be performed 8 hourly or more. And it's been identified in the evidence-based literature that chlorhexidine inhibits dental plaque and gingivitis. And the decontamination lowers the risk of ventilator-associated events like ventilator-associated pneumonia, because the rationale for oral care is to reduce bacteria in the oral mucosa. And as a consequence of that, this decreases bacterial colonization in the upper respiratory tract. And there are numerous devices that can be used to initiate this. Sedation vacation or sedation review assessment with potential weaning assessment is recommended. Continuous IV sedation prolongs the duration of intermittent positive pressure ventilation and increases the length of stay in the intensive care. And as a consequence of that, puts the patient at greater risk of developing a ventilator-associated event. So it's recommended in the literature that daily sedation review is recommended. Stopped but not disconnected, and this allows the patient to wake, and if distressed or agitated, it can be recommenced. If not, it can be considered for discontinuation. How do we know that a patient is sedated? Well, we can use tools such as the Ramsay sedation score, with the objective being a level 2 or 3, typically 3. Resting comfortably, eyes closed, but responds to verbal commands, instructions. Deep vein thrombosis prophylaxis. Well, it's been shown that there's a 12% mortality of ICU patients associated with this condition. So it's essential to promote the use of antithrombotic stockings, pneumatic cuff compressors, anticoagulants such as heparin, or low molecular weight anticoagulants such as Clexane. Nursing interventions also include the primary goal is to prevent complications or detect problems early. Mechanical ventilation affects all the systems of the body, so therefore monitoring vital signs is important. Patient advocacy, I said, is mandatory, and from my philosophy, there cannot be any patient safety without patient advocacy. And this is confirmed in the literature. Competent caring nurses are vital. So they've got to ensure that the ventilator is always plugged in, and in the case of a power failure, manually ventilate the patient. Resuscitation equipment, bagging circuits should be available at the patient bedside, and always check prior to the shift's commencement to make sure that they're appropriate for that patient. Psychological support. Orientate the patient, even if they're unconscious, being sedated, use of neuromuscular blockade. Orientate them to time and date. So for example, what time is it? Night time, daytime. What day is it? Monday, Tuesday, Wednesday. Is it daytime? Is it night time? Explain all procedures, because patients will tell you after they recover from their time in intensive care that they heard everything going on. Ensure that they get adequate rest and sleep, and always provide some form of communication. There are call bells, pen and paper, apps available now, and be visible at the bedside. The patient wants to know that you are there. And if possible, if the unit policy allows it or the organisation allows it, encourage family support and involvement in a nice way. When it comes to neurological system, you can use the Glasgow Coma Scale to assess their neurological state. Sometimes it may not be the most appropriate tool because remember, you may not be able to assess their verbal response because they have got an endotracheal tube or they have a tracheostomy tube. However, it can be modified. It can be modified to benefit you as the healthcare provider and the patient. And this now assesses the level of consciousness, protective reflexes such as gag, cough or swallowing, and you can observe whether they're anxious, depressed, fearful or agitated. The cardiovascular system, you'll observe their heart rate, their systolic blood pressure, their rhythm such as the ECG, the central venous pressure or the capillary refill time. From a pulmonary perspective, it's always important to check the endotracheal tube or tracheostomy tube is secure. Marking of the endotracheal tube and cuff, typically at the level of the teeth. Check the cuff pressures. Cuff pressures are typically at 20 to 25 centimetres of water. Anything higher could induce trauma to the trachea. Check the level of air entry. Check the cuff pressures. Check secretions as ordered or required. The pulmonary system perspective also includes ventilator and ventilation, so it's the nurse's responsibility to check the settings, the mode, the ventilator tubing. I mean, if there's any kinks or excessive water from condensation, it's to be removed. Ensure that the alarms are set correctly and monitor the SpO2, arterial blood gases and the chest X-ray. It's also the nurse's responsibility to be aware of the concept of oxygen toxicity and hypoxia. So it's important that the nurse follows the doctor's orders with continuous SpO2 monitoring, arterial blood gas sampling, and follow the doctor's orders if they are recommending permissive hypoxia and hypercarbia, and understand why. It's also important to prevent gastric content aspiration, which means following the doctor's orders again. Elevate the head of bed if hemodynamically stable or there aren't any spinal issues to 30 degrees or more, position of comfort. Maintain cuff pressures at 20 to 25 centimetres of water and verify that the enteral feeding tube position is in the correct place, especially before feeding. And if you are feeding, check the absorption every 4 hours or according to the unit policy, and omit a feed if the residual is greater than 200 mils, because you don't want to promote aspiration. And if required, prokinetic medications such as Maxilon, metoclopramide, could be considered to increase pericelsus. It's also important to prevent accidental dislodgement of the tracheal tube. Follow the doctor's orders again. Check the marking each shift, secure the tracheal tube effectively, and always be cautious when you're changing the patient's position. And always check on a daily basis the chest X-ray for the tracheal tube position, or if required to check that the tube's in the right position, the chest X-ray following its implementation. Ensure adequate sedation, ensure adequate analgesia, and sometimes, if required, ensure the patient has got soft restraints to prevent any injury, but however this requires patient or family consent. When it comes to humidification, there are two types. There's an active type of humidification which utilizes a heat moisture exchanger, and this is for patients, adult patients, if they're on positive pressure ventilation for less than 3 days. And you follow the manufacturer's recommendations. And the objective of HMEs or heat moisture exchangers is to prevent drying of the respiratory mucosa, mucus plugging, atelectasis. And you ensure that it's changed if it's contaminated. Just follow the manufacturer's instructions. If the patient requires ventilation for more than 3 days, and they're an adult or a pediatric patient, they require passive humidification. And this means utilising sterile water and a humidifier that is heated. And again, this prevents drying of the respiratory mucosa and mucus plugging and atelectasis. And the temperature is typically maintained between a range of 35 and 37 degrees centigrade. Another concern with a mechanically ventilated patient with a tracheal tube is to prevent tracheal stenosis. So maintain the ordered cuff pressures, which are typically less than 20 and certainly not more than 25 centimetres of water. And there are what are referred to as high volume, low pressure cuff endotracheal tubes, which deliver a high volume of air into the balloon but cause a low pressure. It's always important as well to use the correct size endotracheal tube or tracheostomy tube. When it comes to the gastrointestinal system, it's important to check the orogastric tube or the enteral feeding tube. Make sure it's secure, check the aspirate, note the absorption of the feed. Listen to the bowel sounds, because again you may detect a paralytic ileus. Stress ulcers could be a concern, as we indicated earlier with your VATS bundle, and gastric distension. So nasogastric tube would be indicated. Observe for malnutrition, they should be fed. Constipation, immobility, note frequency. So the take-home message with nursing or healthcare provider care for ventilated patients are, again, always consider the science, but always consider the caring in relation to the science. Thanks again. This is the end of part 5. There were 5 parts to this ventilation course. If you're interested or you like what you've seen, check out other Dr. Manny Learn shops on YouTube.